what is a pleural effusion? It is a collection of fluid in the pleural space, which usually is secondary to other diseases, but it can be primary also. That we will discuss in the next slide. Normally also, the pleural space has some fluid which is serous color, and it is for lubrication of the pleural membranes, so they can rub on each other smoothly. This is how the pleural fluid is formed. There is a, on right side, there is a diagram which shows the pleural fluid normally seeps continuously. This is the parietal pleura, this is the visceral pleura, and this is the pleural space. Okay. The pleural fluid normally seeps continuously into the pleural space from the capillaries lining the parietal pleura, from the parietal pleura. Okay. It is reabsorbed by the visceral pleural capillaries and lymphatic system, both sides. This is lymphatic system. So, therefore, any condition that interfere with either the secretion or drainage of this fluid leads to pleural effusion. If the secretion is more or drainage is poor, it leads to the pleural effusion. Now, the definition is clear to you. It's a collection of a normal amount of fluid in the pleural space. This is the definition. How you define? There are of two types: transudate and exudate. Transudate, also known as hydrothoracis, which occur primarily in the non-inflammatory condition like heart failure, nephrotic syndrome, is an accumulation of low protein. It is the fluid is of low protein and also the low cell count. We will discuss in the one of the coming slide that what is the normal protein and cell in the normal pleural fluid. No, pleural fluid which is normally also cause of transudative fusion. These are the causes. When there's an increased hydrostatic pressure found in heart failure, once this is cause, there's a back pressure, or there's a decrease in osmotic pressure, such as in cirrhosis of liver, nephrotic syndrome, renal disease. So, because there is a hydrostatic pressure is increased, the fluid movement is facilitated out of capillaries and into the pleural space, which I showed you in the previous slide. Exudative. In exudative effusions, they can occur. First, this division you can see here. This is fight between hydrostatic pressure and osmotic pressure. Therefore, you can say in this case, the transudative pleural effusion, the pleura is normal, innocent. Here, the pleura is involved. It is not normal, it is pathological. This is between the basic difference between transudate and exudative effusions. Exudative effusion occur in area of inflammation. That's why there is accumulation of high protein fluid. It results from an increased primary capillary permeability, which generally is it is a characteristic of an inflammatory reaction. When there is some infection or some else, there is inflammatory reaction, and the fluid formation is there, such as malignancies, infections, and even embolization, and various other causes like collagen disorders, SLE, or something else, right? So anything which involve the pleura, especially the parietal pleura, that's why we take the biopsy from the parietal pleura, not the from the basal pleura. So these are the various causes like cancer, lung cancer, also breast lymphoma. These all are metastasis to the pleura, and there's a formation of the fluid. There are pleuropulmonary infections like pneumonia, heart failure, with cirrhosis nephrotic syndrome, such as sarcoidosis, which is though rare, SLE, and peritoneal dialysis. Peritoneal dialysis means when you do the peritoneal dialysis, there can be also the fluid, and this fluid transgressed through the diaphragm to the pleural cavity, and its biochemistry is like the peritoneal dialysis. It is the same fluid. So again, it is further to understand how the transudative is formed. So I already treated this increase the hydrostatic pressure, this is parietal pleura. This is diagrammatically I have shown you. This is the pleural space and this is pleura, and it has the hydrostatic pressure 24 plus and plus 30, and osmotic pressure is 34. Okay, the parietal pleura, and 34 both. And in pleural space is -5. Hydrostatic pressure is -5. Plus supported pressure is put in +3. So these are all the calculations which you can see on video or otherwise, or you can see your in books on the diagrams, so you can understand better these calculations. Then there is the increased hydrostatic pressure or decrease in osmotic pressure on the pleural floor, and in the capillaries, it is unable to remain the fluid within intravascular space. It comes out from the interstitial space and into the pleural cavity, which ultimately leads to formation of effusion, which is known as pleural effusion. Exudative, for example, there is invasion of the bacteria, which causes the irritation of the pleura, pleural membranes. It causes the vasodilation. You know all the stages of the inflammation, and there's an increased capillary permeability, leads to lack of plasma protein and decrease oncotic pressure in the blood, which further help shift the fluid into the interstitial space and the pleural cavity and formation of the pleural effusion, exudative pleural effusion. But the clinically, how the present clinically? Usually, the clinical manifestation are those caused by the underlying disease. Pneumonia, like pneumonia, session of the heart failure, and it depends on the severity of the effusion, mild, moderate, severe. Like for like pneumonia, all causes the fever, chills, political pain. Effusion result from dyspnea and coughing. Because by malignant effusion I've taken, because malignant effusion is always severe, generally. And also there can be symptom of the malignancy from where it has come. When there is a small to moderate pleural effusion, present dyspnea may be absent or only small breathlessness. There can be chest pain, and there's a dullness or flatness to percussion, decrease or absent breath sound. We will discuss again. Always do general physical examination. See the patient conscious, oriented, patient febrile or afebrile, the blood pressure, respiratory, pulse rate, clubbing is there or not, patient is cyanosed or not, jaundice, and look for the lymph nodes, peripherally as well as central. So this is a chest examination on pleural effusion. what happens? On inspection, there is a reduced chest wall movement of the affected hemithorax. There you can see on inspection, there is trickle shifted to the opposite side. Okay. The kyphoscoliosis apex feet localization and look for the kyphoscoliosis. It has gone down. Okay. Scoliosis. On palpation, you will see is a decrease or absent vocal parameters. Trachea shifted to opposite side. Apex feet localized, it is shifted or not. Then it can shifted to the opposite side. Again, look for kyphoscoliosis. Supposing if shifted, the trachea shifted to the same side. Generally, included fusion is shifted to the opposite side. If it is shifted to the same side, that means there is a also associated collapse of the lung on the same side. That may be some due to the intervocal growth or foreign body or whatever it is. There is a collapse of the lung of the same side. On percussion, there is a dull note and shift in dullness. You always forget in the examination, look for the shift. There is a dull note on the same hemithorax. If it is a bilateral, then both sides. And always look for the shifting dullness. On auscultation, you will see there is a breath sounds are absent. There can be friction rod, this is egophony and discussion splash. Last time also I discussed with the one case discussion and somebody asked me what is egophony. So now this time I will tell you what is the egophony. This is the like and breath sounds. The voice sounds are also reflected by fluid air. You know, but the sounds are reflected by fluid air. The pleural cavity has a pleural effusion. The speech is unaudible on the chest wall. Both pleural effusion and pneumothorax. Okay. The voice sounds also show the same thing. Voice sounds mean when you say 1, 2, 3, you ask the patient to say something. Here, when constricted lung is separate from the chest wall, only with thin layer of fluid, there is attenuation at the interface between fluid and two layers of the pleura is selective. Why selective? Because the in team, say TEM, in team, E has the formats. That means double frequency. One is up to lower is 400 hertz and uppermost is 24. There's a lot of difference. Okay. While in other A, it has 800 or 725, something like that, hertz, lower frequency, and other is 1200. So what happens? The frequency below 1000 are lost. So that only high frequency formats of vowels survive. A, E, both are survive, but lower, below 1000 is lost. Thus speech remains intelligible. It can be comprehensible, but removal of lower frequency vowel sounds leads to the nasal bleating. You know, when there is nasal bleating. Okay, अभी मैं आपको करके तो दिखा नहीं सकता हूँ कैसे होता है. So how is it identified? You ask the patient to say E if it is present. The E will be heard over chest wall R. Okay. E. So the epiphany is usually detected only over an area of upper area pleural effusion. where fluid is thin and underlying there is a consolidation. Because below there is a very not a thin layer, but a thick layer of the fluid. And as you go above from lower side to upper side, there the fluid, the layer will be less and less. So there is the fluid layer is thin, there is a eugophony is present. You always, when there's a fluid, you always look for the discussion splash. On last week, there is an MD class. The pleural effusion patient, they have not seen the always see the discussion splash when there's shift and less and succussion splash. Generally, you miss in the examination. It's harder than hydropneumothorax or bronchopulmonary or if there is a very big cavity. Okay. In hydrotherapy or chest wall, air fluid, there's a fluid, this is the air, this is the interface. To keep your stethoscope here, and you or your assistant will shake the patient. You will see that sound like from the picture. जैसे घड़े से छलकता है ना, वैसे आवाज आएगी आप. ठीक है? So this is seen in also normally also on the stomach when there is you have taken the water, and again in the stomach is a cavity. Stomach is a cavity, and there can be some fluid and air or some hernia also. But you should only remember this one three only. If they ask और भी कहाँ सुन सकता है, say that it can be also in the stomach. ये पूछते हैं आपसे. Effusion का पेशेंट मिलता है अगर वो होता है तो. So in healthy man, I've already told you this rule full in 10 to 20 ml. With the low protein. When the field can be seen in the many times the people will say this is due to the capillary reaction. This is not due to capillary reaction. There is a fluid. Here is more. That's why it is a more thick here. As you go up, this is the rays going through the lungs becomes less. That's why it looks like concave. On ultrasound, generally we do the ultrasound now. So to keep the transducer, the radiologist keep the transducer perpendicular to the dorsolateral chest wall, and the measurement is taken at maximal inspiration. The radiologist measure the distance between the viscera and the parietal pleura. Okay, and how to calculate the volume? This distance into 20. Okay, how much ultrasound can, if it is 100 ml, the ultrasound detect it. Many times patient is sent for the ultrasound of the abdomen, and they pick up there is also fluid is there. Many times it happens. CT scan is not become necessary now. As you show in this patient is only pleural effusion, but in the same patient, there was a right side pleural effusion, and on CT scan, there's some subtle changes are also there. Just associated often, that means like some cavity, which is not visible there. It was not appreciable on the radiograph. So always do all the investigation, hemogram, KFT, lab, TKG, photography. The most important is to aspirate the pleural fluid. Aseptic conditions. Generally, you draw the 50 ml the fluid for the analysis. Like this was normal characteristic I told you. I will say that it has the pH. The reason for the parietal pleura, which I told you in the beginning, pH is 7.6 to 7.64. Protein content is 1.1 to 2. Cells are fewer than 1000. Glucose is almost similar to the blood plasma. LDH 50% of plasma. ED less than 40 international units. But what happened? Exudative, transudative. How to distinguish? Generally, you are asked the, if there is you are given this case, asked us to tell the what is the light criteria. Okay, the light criteria is when the is accurate if one of these three is present. If the effusion protein and serum protein ratio is more than 0.5. Same the LDH of fluid and the serum is more than 0.6, or even if the LDH level is also the reference range of the is present, then in the beginning also we want to distinguish between exudate or transudate because it gives us the clue that in exudate the pleura is pathological, in transudate pleura is innocent, normal. So here we do the biopsy. Here we should not do the biopsy. When you will be intern, you should, or PG, never do. I have seen maybe in a time, even this is exudate. That in that case, the exudate becomes because they give the diuretics, and diuretics give them uh, false picture of the exudate, and they do the aspiration. So you do not the aspiration in the transudate. Okay. In exudate, pleura is pathological. In transudate, pleura is innocent. So we have to do the biopsy only in exudate. Always, because in our country the TB is very common, so we always send the fluid for if we smear examination, otherwise there's a net and the PCR to look for the mycobacteria present or not. Generally, it's a smear is very rare to see, but with PCR one can have the some positive patients. Fluid biopsy, I told you, further cause of the pleural effusion, diagnose tuberculosis, cancer, or other diseases, whatever it is. So treatment depends on the etiology. So I will not discuss the treatment extensively, but some there is conflicting points are there which I've discussed with you. In when you are treating tuberculosis, the steroids could be given or not. There's some evidence. There is a when people say there's no definite evidence, but I will say there's a definite way of benefit of the corticosteroids. It leads to the rapid drainage of the fluids as well as the reduction in the residual effusions and a possible reduction in the full adhesion and thickening. When you show the pleural fluid drainage, large effusion, because patient is dyspneic, put the chest tube. If it is small, it is only the if it is small, the thoracic relieves the dyspnea rapidly associated with long-term reduction in residual pleural effusion, thickening, and minor improvement in the lung infection. Patients with local diffusion are more likely to have residual fluid thickening with reduction in forced vital capacity. So people are given intrafluoral fibrinolysis and streptokinase, urokinase. I think again it has because this streptokinase is very expensive and effect is maybe very minor, so we don't achieve much more. Okay, but if there is a pleural fluid is very heavy, severe, and caught in dyspnea, you should the drainage, put the chest tube. So now we will shift to the next topic. So I will start after 2-3 minutes. I will take out the slides of the other topic, empyema. So you also take just for 2 minutes, 3 minutes. Let us start with the next topic, empyema of thorax, empyema thoracis. We will discuss this topic under these subtopic like definition, etiology, victoriology, and complications. What's the definition of the empyema? Any empyema is a pus. It can be in the gallbladder or anywhere in any pleural cavity is a pus. In any cavity, gallbladder is also a cavity. Empyema gallbladder. So this is the presence of pus in the pleural cavity. Generally, it is not a perennial disease. As I told you many times, they do the, especially the private people or novice, they don't know about the pleural effusion. They put the fluid in the transudate effusion also, and during that procedure, they inject some infection which lead to the later on the empyema, which is not that easy to treat also. It is not a primary disease, I told you. Some underlying diseases are there, or it very complication of the some other disease like liver abscess, pus in the peritoneum, or abdominal infections. So the etiologies can be local causes, it can be systemic causes, like local causes related to osteomyelitis or ribs. The infection goes inside, penetrating wounds, and accidents or otherwise can lead to the infection of the pleural cavity. Testicular abscess again, it's adjoining to the pleural cavity can cause. So the pleural cause, the pneumothorax, hemothorax means there is a blood in the pleural cavity. Very good culture media for the infection. So that's why if the hemothorax or clots are present in the pleural cavity, these are moved should be immediately. One should not wait much because there is it otherwise lead to infection and empyema. The primary causes pneumonia, bronchitis, already told primary tuberculosis, lung abscess, bronchiectasis, because there is infection lead to pneumonia. Cyberdiagnostic causes like subarachnoid abscess, liver abscess, subarachnoid abscess, or liver abscess, or pus in the peritoneal cavity, iatrogenic, and doing the endoscopy. One can do the esophageal perforation, and the pleura is just adjoining. It leads to the infection of contents of the esophagus go into the pleural cavity. Pleural tab, which I told you, pleural tab, sometimes, which is not required pleural tab, and do the pleural tab. Okay, or after surgical operations, there can be also like post-pneumonectomy or post-thoracotomy. Sepsis. There is seedling of the bacteria in the pleura can lead to the. These are common organism which causes Streptococcus aureus, Streptococcal, Listeria, E. coli, Tuberculosis, Aerovector, Proteus, Salmonella, and anaerobic bacteria. Empyema is classified by three types, three classes: anatomically, can classified, clinically, or pathologically. Let us start with anatomically. It is a protothoracic empyema. The whole rule is involved, or it is a localized or thoracic empyema. I told you that always do the shift in dullness. If shift internals is absent, that means it's localized. Or of course you have to do the other investigation like ultrasound or CT scan, but clinically also can look for. If shift and dullness is present, that means it's a free pus. Clinically, it can be acute, subacute, and chronic. Is in acute, the presentation is when there is a toxemia shock, like penetrating wound is there, septicemia. Patient present with high-grade fever, cough with periodic chest, flutic chest pain, and shallow. Acute is left sweet for when it's less than 3 weeks, it is known as acute. Okay, 3 to 6 weeks, it is subacute. When it's more than 6 weeks, it is called chronic. Subacute is less severe form of presentation in patients who was on antibiotic pneumonia. Chronic, this usually results from the mismanagement of the acute form. Many times we always encounter with the chronic. Many times the patient comes with the just they say, I'm not feeling well. I feel unwell. And sometimes I've got fever, there's loss of appetite. When you do the X-ray, will there be the whiteness of the one hemithorax? And when you tap it, you can see there is a pus. Many times there is the indolent course, generally, but we find here because of the referral hospitals, बाहर से बिगड़ के केस के आते हैं, ठीक है? We generally indolent courses there. Pathological condition, exudative. Initially, there is exudate, is infection, exudate. Then comes the fibrin and becomes purulent because there is lot of cells. Then this ultimately leads to organizing. Empyema, cystic empyema, local-related empyema. The exudative, purely an inflammatory process, which we already told you. Then an increase in the permeability of small blood vessel leading to exudation of fluid. This fluid is thin with low cellular content and underlying lung that expands rapidly if you treat ear at this stage. Otherwise, when fibrin is established stage is characterized by large number of cells, leukocytes, polymorph. There is a deposition of fibrin on both visceral as well as parietal pleura. There is a bacterial fusion on the pleural space, and there is a tendency because there is a fibrin is there. So there is a tendency towards the loculation formation. That's the second stage. This will become a little difficult. Organizing stage. In this case, the fibroblasts also appear in the now heavier form. In the where is the fibrin deposition is there, and the fluid exudate becomes very thick, and there's a loculation and septic form, septa formation is there in localizations, septa due to the fibrin. And here it's very difficult to aspirate, or if you put the chest tube, the whole pus is not drained. Pus is, you have seen, probably have told in the surgery, if the pus is anyway, you have to drain it. The clinical presentation is generally the symptom of cough, chest pain, breathlessness, fever, rigor, generally body weakness, indolent, course they generally have not not feeling how bad. City to obliterate the empyema thoracis. You have to train the pus. How much the expansion of the underlying is depends on the pathology of the pleura. But we have to prevent the complications like pleural thickening because ultimately it leads to the dyspnea and patient has to go under surgery. It depends on the stage. Non-surgical antibiotic initially intrapleural thrombolytic agents, which I told you it's very controversial. Needle aspiration. If it's small pus, sometime you could always do the thoracentesis and it is treated. But generally, you have to put the chest tube. Thoracoscopy, closed chest drainage. This is very important. Generally, it's done in all the cases. And it goes on drainage for months together. If it is not drained fully, then you have to the open chest drainage section of the rub. Many times when the fluid is thickened, you have to the decortications. The fibril deposition is removed because when is a thickened pleura, very thickened pleura, it restricts the movement of the lungs. Patient is breathless, especially on exertion. And many times we have to the thoracoplasty. Needle aspiration. Okay. Close chest, open chest, resection. 2-3 ribs you have to resect. Okay. And again, then you have to put the chest tube. Decortication is not treated properly. The patient is restless on exertion. That means the thickened pleura is good thickening is established, and you have to peel out the cortical layer over the right line of the pleura so that lung can move properly. And thoracoplasty, it is rarely done now. Okay. Complication, septicemia, respiratory insufficiency, bronchopular fistula, lung collapse, empyema necessitates. You must know empyema necessitates. That means the pus is coming from the pleural cavity to the skin. Okay? But it can go to the abdomen up to the inguinal ligament also. Empyema necessitates. Of course, because if there is a coronary infection, it can lead to the amyloidosis. Then there is a patient of consultation, and the patient has also the pleural effusion. You are always asked this question, and you can have a note also, short note on the parapneumonic effusion. What is parapneumonic effusion? It is a pleural effusion that forms in the pleural space adjacent to the pneumonic consolidation. How it happens when a microorganism infect the pleural space? A complicated, this is known as also the complicated parapneumonic effusion or empyema may result later on. That's why at this stage, the prompt therapy of this is life-saving. Okay, you would immediately aspirate. Current effusion, these are the categories. Category 1, when less than 30 millimeter, is the thickness. No fluid analysis should be done because it's very difficult to aspirate. So no drainage is very good. If patient become all right at this stage, it is okay. 10 millimeter. If it's negative staining, again prognosis is good. If the 50% of hematology involved, that loculation, osteogram stain, pH less than 7.2, that means pH is low because there is a load of bacteria there. They have consumed the glucose and form the lactic acid, and which causes the lowering of the pH. Here the prognosis poor. You have to do the same thing which I've told you in the Empyema. At more than 50 loculating a thickened pleura, frank pus is there, then same thing, complete drainage necessity is there, chest tube is there. You have to put the chest tube. Now, any question? Any question? Any question? लगता थक गए आप सारे. Yes? Nobody asking any question? आप वहां सुनते भी हो कि छोड़ के चले जाते हो ज्वाइन करके? क्वेश्चन पूछते ही नहीं हो. कोई एक आधा तो पूछो भाई. एक आधा क्वेश्चन तो पूछ लो. No? Again, I asked you. Okay, somebody asked. Differentiated clinically. What differentiated clinically? Vaishnav? Differentiated clinically means what you want to differentiate clinically? Future classes. But ये कोई कौन सा क्वेश्चन है future classes? हैं? ये कौन सा क्वेश्चन है future classes? Somebody has asked. Future classes. You can ask this from the medicine department or the future classes. Any other question? Okay, if there is no question, then we stop here. Okay, bye.